on 1 o'clock at the moment, so we're seeing more and more people join, but we'll get going with some just basic housekeeping and introductions while more people join. So welcome to this SHOT Meet the Experts webinar. Excuse me. Today's webinar is on information technology. It'll involve a 20 to 25-minute presentation followed by a Q&A session and then a feedback poll at the end. Your microphone has been muted for the duration of the webinar. The webinar, as you may have heard just then with the prompt that came in, is being recorded, so just to let you know about that. There's no chat facility during this webinar, but if you have any questions, we invite you to please write them in the Q&A box and we'll endeavour to answer them during this session. We welcome lots and lots of questions, please. It's your opportunity to make the most of the expertise that's available today. We've enabled captioning from the back end of Zoom, so if you wish to turn this off, you can do so from the toolbar and select hide captioning. Just to mention, we've got another Meet the Expert webinar coming up on the 20th of January 2025, and the topic for that one is going to be human factors and ergonomics, and you can check on the SHOT website if you wish to register. That's already open. So without further ado, I'm going to move on to introduce the speakers. So today our panelists are Dr. Megan Rowley, who is the SHOT Steering Group Chair and previous IT Working Expert Group member and very active member of Script. We have Mrs. Nicola Swarbrick, who is the SHOT Laboratory Incident Specialist and also a member of Script. Dr. Jen Davis, who is Transfusion Laboratory Manager at Royal Devon University Healthcare, NHS Foundation Trust, SHOT IT Working Expert Group member, and also a very active member of the Script Group as well. Jenny's succumbed a little bit to the winter bugs, but she's very much on hand to give her expertise for any questions you may have. So over to you, Nicola and Megan and Vicky. Thank you.
Thanks, Emma. So I'm going to start by talking about the information technology errors from the 2023 SHOT report. And then Nikki's going to take over and talk a little bit about downtime and cybersecurity, and then we're going to tell you about Script. So first of all, from the SHOT report 2023, these key messages kind of sum up our current view of the importance of the IT chapter. We know that transfusion-related IT systems can prevent recurrence of errors in clinical and laboratory transfusion practice, and that they improve patient safety. There's increasing recognition of that. There's a very important message is that transfusion-related IT should be implemented correctly, or existing systems should be modified appropriately. And then very much it's how we learn from both the SHOT errors and from each other. The learning from the implementation of transfusion-related IT systems should be shared with others, particularly those involved with procurement, implementation, and operation of these IT systems. So by way of background, I think that's really important. And what transfusion IT systems are we talking about? This is really a summary of all the IT systems and automation that exist within transfusion. Some of them are specifically transfusion IT systems, and some of them are more general hospital and healthcare systems. So most of us will have a laboratory information management system or a blood bank computer, and most people will have some sort of clinical IT system like a patient administration system. Increasingly, people are implementing clinical systems such as either electronic blood management systems, or sometimes referred to as electronic transfusion systems, where they work at both blood collection and at the bedside. And then, of course, we have other systems such as electronic patient records, which are increasingly replacing the paper patient records that we're all familiar with. And then on the service provision side, we've got a number of things like temperature monitoring systems and blood ordering systems. So all of these contribute to this particular SHOT chapter, and I will be referring to these as we go through. But before I say that, the most important thing is that these systems speak to each other. You know, you can't have the benefits of a digital system and digital information unless it's being able to transfer from system to system. And this is a theme that will run through my presentations today. They are safer, they are more efficient. By way of background, of course, there have been two key publications in the last couple of years. The first in January of this year is the BSH guideline for hospital transfusion laboratories. I think this is about the fourth reiteration of this. And although it started off mainly covering the laboratory systems, it now covers both clinical and laboratory systems. And it should be read in parallel with the BSH compatibility guidelines and the MHRA guidance for electronic issue, but it covers all the key elements of IT in the hospital. In the appendices on the BSH website, there are a number of useful appendices. This is a very long and technical guidance, but I think, you know, if you refer to the relevant section, it will be of very good use to you. But the most important thing is that there's a gap analysis tool so that you can use that to see where you are in relation to the guidelines. The other thing that's been published in 2023 was the updated UK TLC standards. And Standard 3 covers information technology. And I've summarized these things there. You really need to go to the SHOT website to look at the recommendations in detail. But there are three sections I've summarized here. One covers the importance of complete walk-away automation in use all the time. The second covers the important element of the LIMS, including compliance with the guidelines, but also the key things that your LIMS should be able to do and the key things that should be able to prevent, like preventing incompatible transfusions. And again, the importance of contingency for planned and unplanned downtime. And then thirdly, the promotion of these electronic transfusion systems. Now, this is not a new standard, but both SHOT and the UK TLC and many other clinical transfusion recommendations cover the importance of having these systems vein to vein that are used to their full functionality, and also other digital systems such as temperature monitoring systems, and the fact that they should be interfaced and have full electronic transfer of information. And there's a gap analysis tool available for this. So if we go on to the next slide, we'll see that the recommendation from the IT chapter this year is to use these tools to undertake a gap analysis for all existing transfusion-related IT systems and automation, and also compare them against the BSH guidelines and the standards. And then when you're implementing a new system, make sure you refer to this guidance because it will stand you in good stead. Of course, there are other drivers for improving and implementing IT. The infected blood inquiry, I'm sure you all know, was published in May of this year. And we were very pleased to see that recommendation 7F covers different aspects of IT. There is one recommendation around recording the outcome of transfusions for all recipients. And this is beyond traceability, really. This will include sort of hemovigilance, adverse events, and also clinical outcomes as they relate to things like patient blood management. So there will be some work ongoing to try and develop this framework. And then also there will hopefully be some funding forthcoming to support it. And then the final recommendation, as has been recommended, I said before, by lots of other people, is to make sure that we have enhanced clinical electronic systems to support patient safety. Second thing is that, and this applies to England mainly, but I think it is relevant to all, Transfusion 2024 has now been replaced by Transfusion Transformation. And there was a symposium in June of this year to reflect on the infected blood inquiry and to move on all the work streams that were in Transfusion 2024. And work stream 2 is about transfusion digital interoperability, and it covers blood management systems, data integration, and diagnostic capability. And if you want to see the full output from that, there's a link there, but you can also go to the NBTC area on the website, and you'll be able to see that. So the IT chapter is a composite chapter. It's a secondary chapter. So taking all the primary reports, we extract those where there are errors caused or contributed to by IT systems, errors caused by using these IT systems incorrectly, and errors where implementation of an IT solution would have or could have prevented the error. So it includes corrective and preventative action in response to an error where it included an IT solution. And this is the data from this year. There were 541 reports, fairly evenly distributed over clinical and laboratory errors as the primary error, and including the usual error categories that we have seen before. There are a few other cases that are analysed. The anti-D cases are always analysed, but not necessarily added into the total. And also we have a look at near miss and wrong blood in tube errors to see whether there's an IT element to that. So these 541 reports, I think we've been reporting having an IT chapter since 2006, and every year, year on year, the number of reports has increased. This year, there was a 40% increase in IT-related errors, and previously it's about 13% of reports. This year, it's 17% of reports had an IT element. Difficult to say why. I'd like to say it was because people are recognizing this more and reporting it. What we did observe within this reporting period were there were a lot of new systems being procured and implemented. So, and you can see there the categories: specific requirements not met and whole wrong component transfused comprise the largest number of errors, and I'll go on to explain that in a minute. We also have a large number of handling and storage errors. Thanks. So we have expanded the IT questions over the last couple of years, and we analysed those in detail this year. And I think it provided a greater reflection on both the source of the errors and the possible solutions that might rest with IT systems. So the first question was, did IT contribute to this error? And you can see there that 28.8% of reporters said yes. And that means that 71.2% of the cases were not identified by the reporters themselves. They were identified by the SHOT team. And I think that sort of is important to recognize that even if you don't say that this is an IT error, we will look through the whole report and we will include it if we think that there is something to learn from it. The second question was, could the error have been prevented using IT? And it was really encouraging to see how many people had reflected on this and said yes. So 47.9%, nearly half of the people who reported these cases identified that there was a need for greater use of this sort of technology. So I mentioned before we include IT systems as corrective and preventative action, and there were 64 reports that stated CAPA included an IT system. And this was largely around either additional functionality or additional systems needed, deemed necessary to reduce the likelihood of the error that had been reported occurring. Many of these had been specified, procured, and were at various stages of implementation, and approximately half would have prevented the errors had they been fully operational. So I think, you know, as I said before, there being quite a lot of new systems being introduced, I think this is something that we need to keep an eye on. You need to be aware of. There were a number of people who said yes, IT would have prevented this error. Our CAPA includes an IT system, but many of those people identified that no specific funding had been identified, and there may not be the capacity to implement new systems that would have the potential to prevent these errors. So if we look at these top 5 errors, you can see that 5 of them include warning flags, alerts, logic rules, and algorithms. And if we move on to the next slide, I'm going to talk about these in a little bit of detail, as they are the commonest category of errors when we analyze the reports. So algorithms for safe transfusion practice cover things like component compatibility, specific requirements, sample validity, electronic issue of red cells, many other things. So in the 2023 report, there were these three categories. 66 alerts and warnings were already in place, but for some reason were either overridden or not heeded, or perhaps not understood. 56 flags were in place, but they were not necessarily updated in a timely way, or they had been removed in error, and therefore the component was transfused. And then there were 72 cases where there were flags or logic rules available within whatever systems, but they weren't activated, or they weren't used, or they weren't populated. So, you know, this is what can occur. So my first case is where an error message was misunderstood, and it led to blood being transfused beyond its expiry date. So ward staff were administering blood to an unwell patient who needed an urgent transfusion, and they got the error message dereservation from the electronic blood management system. And they reverted immediately to a manual independent two-person check, which was the contingency system for downtime. Neither of these people noticed the use by time on the blood bag tag, and it was transfused beyond its expiry. And there had already been a delay in collecting blood, and there was no written or verbal communication from the laboratory indicating that the unit was close to expiry. The context of this is there had been repeated error message from this system, so that staff concluded that the system wasn't working as expected and went straight to the downtime procedure. So there was already a degree of alert fatigue, and the error message was not understood at the bedside to mean that the unit had expired. So my next case is also related to the electronic blood management system, but it actually started in the laboratory. So here we have a 2-unit apheresis platelet donation, and the wrong pack was selected from this 2-unit donation and issued electronically. And the discrepancy between the codes was highlighted when the platelet was collected from the electronic blood management system. So it went back to the laboratory reissued the same unit, but the discrepancy remained because they hadn't worked out what it was, and the alert was overridden. The same discrepancy was highlighted at the pre-administration check, and again was overridden, and the unit was transfused. And clearly this was the right unit for the right patient, but nevertheless, both of those units were overridden. The error came to light when the second pack from this donation couldn't be issued because it had already been fated as transfused. And that's how the error was identified. So lack of clarity of alerts can cause messages to be overlooked or misunderstood by clinical and laboratory operators, and staff in the laboratory are not always able to support clinical staff who contact them with queries about error messages. It may sometimes be due to lack of familiarity or inadequate training, but also it can sometimes happen with lone workers due to competing priorities in the laboratory. So the learning points from this is that error messages should be clear and specific, and that everybody should be able to understand what action to take in response to an error message so that you maintain the patient's safety benefit of that system and also at the same time minimize delays. And when training in the use of these clinical and laboratory IT systems, you must include troubleshooting advice. So when a problem has been identified, obviously it should be investigated and resolved appropriately, but then the learning from that incident should be disseminated widely and added to any future training resources. I've mentioned interoperability before. Lack of interoperability can lead to a number of errors, and you can see here there were 55 reports related to interoperable systems. There were 23 that related to a patient ID discrepancy between the laboratory system and the clinical system, which resulted from an IT error, although blood components were issued to the right patient here. There were 24 errors where there was failure to link, merge, or reconcile computer records on different systems. And then another 8 cases where historical data was available on an IT system, but the record was not accessed for whatever reason. It may not have been accessible, or but it certainly wasn't used to issue the right component. Next slide, please. And this is an example. This shows what happens when there are 2 medical record numbers in use across linked hospital site. So a request for red cells was sent to the transfusion laboratory from another hospital site. 2 units were cross-matched using the hospital number from the main hospital site and transported to the theatre refrigerator. And when a member of staff came to collect the first unit, the system said there was no blood available for the patient, but they then used the emergency access facility, rightly or wrongly, and found that blood was located and found to have correct identifiers, except for this discrepant hospital number. So there was a shared LIMS across these 2 hospital sites, which used site-specific hospital numbers as the unique identifier. And although the NHS number, which would have been the same on both sites, was included in the patient record, it was for information only. And the reporters commented that the LIMS was due for replacement, which may represent an opportunity to resolve this lack of interoperability. Next slide. So again, we mentioned at the beginning that we also look at the function and use of IT systems, and there were 98 cases where the systems were not function optimally or not used correctly. Some of these related to the laboratory system and some to the electronic blood management system. And then there were additional errors arising from manual processes. So selecting the wrong record, for example, 24 reports from entering data incorrectly into an IT system. So the learning points, which are really from previous years as well as this year, that when implementing or updating systems, ensure appropriate validation to make sure that the systems work as intended. And most importantly, where any unexpected errors occur or IT systems don't function as specified, make sure you work with the software manufacturer to resolve your problem locally, but also highlight any faults so that all users of the system in other sites can benefit from any improvements. And this is an example of functionality. I'm not saying that this was not functioning as intended, but I'm just saying that it's quite a useful case. So this is where cross-match blood couldn't be collected because the system was updating at the time. So a member of clinical staff who was fully trained and competent at using the electronic blood management system clicked blood products out on the kiosk and entered the patient's details. And then an error message appeared saying, please try again or contact support for assistance. That's very specific. The alert was acknowledged, but to avoid delay, emergency blood was collected instead of the assigned units. And when this was investigated, it was identified that the laboratory had just issued 2 further units of red cells, which were being transferred into the remote electronic issue system. So the patient's record was updating at exactly the same time that the other units were attempted to be collected. So the kiosk wouldn't allow that blood to be collected. So I would say this error message was specific, and had an attempt been made to collect the blood, the system would have allowed the blood that was issued to be labeled rather than the emergency blood collected. So as you know, SHOT does a lot of work on human factors considerations. You can see that human factors relate to IT systems at many, many different stages of implementation and operation of the system. Next slide, please. So our recommendation also from this year is when introducing new systems across any part of the pathway, consider human factors and ergonomics so that you gain all the possible benefits of technology, and that is for patient safety, but also for the usability of the systems by staff. So my final summary slide really brings all these points together, some from this year's report, some from previous year's reports. When you implement a LIMS or any system, it must be set up appropriately. It can be helpful, it must be correctly set up. IT can introduce new errors, of course, both clinical and laboratory errors. We have recognized alert fatigue, cognitive bias, and over-reliance on IT. So we must get that balance right. Alerts must be understandable and actionable. And again, interoperability between systems is key. So it is also important to have contingency plans for downtime. And I'm going to hand over to Nikki now, because she's going to talk about downtime and also cybersecurity. Thank you.
Thank you very much. Yeah, my first case, just to bring this subject up, we had an IT server failure causing multiple operational issues. So there was a failure of the power supply to multiple servers, which caused the uninterruptible power supply had been set up in the wrong way, and it wasn't in accordance with the design that it was meant for with this system. So unfortunately, the knock-on effect of that was that caused multiple systems to fail. And unfortunately, in this instance, it also included the electronic blood management system, all the remote issue fridging, and that ultimately led in delays to transfusion of bleeding patients and of an unnecessary use of emergency blood. There were additional IT related communication issues all to do with this case as well. And the bleep, unfortunately, because of this downtime, the bleep system was down. You couldn't get specific help and guidance on those issues, and they couldn't get access to the telephone directory, so they didn't know who to ring and how to contact them. Had they been able to contact the lab, hopefully the theatre staff would have been reassured that there were fully cross-match units available for this patient, and they wouldn't have it wouldn't have impacted the patient in the way that it did. So obviously it's very topical at the moment. It's going to lead me on to talk about cyber attacks. The data I'm going to show you now is for the data we've received this year. So this is not published data as yet. It will be included in our SHOT report that will be issued next July. But obviously, it's a very topical thing. So we wanted to include a couple of slides just to show you what kind of things we've started to see. We are keeping these cases to one side as well, so we can trend and we can and make sure that we're really keeping on top of these issues. So what kind of things? These are the categories we're seeing errors reported under. So wrong component transfused. Obviously, if you've got no access to patient records, you're going to miss those specific requirements. You're going to miss transfusion requirements. In this instance, we're talking about transplant cases, obviously quite complex patients as well. So you really need that access to patient's record. We've also seen errors to do with manually inputting of groups into like a secondary system. So that might be EBMS systems that have allowed units to be issued with tags, and that's unfortunately led to the wrong D groups being issued. And we've also seen wrong component types being transfused due to hematology errors. So where the wrong result has been inputted. I think in the instance we're talking about platelets for red cells transposed as well. We've also obviously going to see lots of patient ID errors. We've got incorrect details on samples, incorrect details in systems, and that's led to a lot of right blood, right patient issues. Specific requirements not met is not a surprise. If you've not got access to patient records, you're not going to be able to see particular antibodies. You're not going to know what phenotypes to give. There might be irradiation requirements. You're going to miss those alerts. We've also seen where they've not been able to update alerts, even when that information was known, and when alerts were available, maybe in a historical system, that they've not been actioned either. We've seen delays, so that was mainly to do with blood availability in cancelling theatres and components not being ordered to allow the staff in the lab to issue those units, and avoidable. So that was talking about the avoidable use of emergency stock. So in summary, we see obviously any manual input of results or any manual input of patient details is always prone to error, as this ties completely in with all the things that Megan's talked about. If you've got a manual system, you're potentially going to see errors. Existing alerts not viewable, new alerts not being actioned. No backup plan for system downtime. Obviously, some of these are completely unplanned. It's having a really robust business continuity plan, which we will go on and talk about, and it has led to issues with blood availability. Now, the following slides, I'm going to talk about our Jenny slides. Unfortunately, she's not very well, but she is with us for the Q&A session at the end. So please do, if you've got any questions at all, please do save them, and you can ask them. I think you can ask them in the Q&A chat as we go along, or you can save them for the end. That's absolutely fine. So I'm going to talk to you about script. It is the SHOT UK collaborative reviewing and reforming IT processes in transfusion, hence why we refer to it as script. Effectively, we are a working expert group. It was formed back in 2019 because the SHOT team were seeing recurrent themes in the SHOT reports relating to IT and failures within the LIMS system. So mainly, as this obviously follows on from what Megan was saying, you would see an awful lot of alerts and flags not being heeded or not being or alert fatigue, people not actioning those alerts. And we're talking about algorithms for component compatibility, sample availability, and EI. So these are the kind of things, these are the errors we'd started to see within the SHOT team. So the working group was put together with the overall aim to improve transfusion safety in the UK through improving IT systems and practices. So one of the first things that were done was a user survey was sent out back in November 2020, and it was just to try and ascertain the current state of IT. So it asked a variety of things, all the way from electronic blood management to do with the LIMS in the labs, temperature monitoring systems, interoperability, the kind of support you were receiving from suppliers, and what sort of expertise to do with IT did you have in hospitals? What did you have access to? So it's an awful lot of questions. And these are the challenges, the kind of things that we saw in those responses. So interfacing and interoperability between systems, communication between hospitals and their suppliers, things to do with validation and revalidation, not being particularly sure of what needed to be revalidated, and that line of communication with suppliers. It also mentioned things like user requirements for new systems, and understanding the responsibilities for validation. So what script did was then we asked about the barriers. What kind of barriers do you face when you're implementing IT systems? So none of these will come as a surprise. Financial engagement, trust engagement, and staffing resource. And there's a little comment there. So this was a particular comment that somebody had made when the survey was sent out. Lack of support from Trust IT, way too much red tape, lack of funding, lack of support. And I'm absolutely sure if you've implemented an IT system in your trust, I'm sure you've come across some of these. There will be positives as well, but I'm sure some of these issues you will have come across. So what this is focusing on the LIMS. So what those LIMS questions that were asked, we part of that survey, we looked a little bit deeper. We looked, and there was a lack of interoperability, which is what Megan had mentioned. Deficiencies in functions were the functionality within the IT to build rules and algorithms to make sure that different patient groups or different ages were provided with the blood and the components that they needed that was the safest for that patient group. And there were financial and resources pressures as well to support any upgrades that were necessary. So when we look at those LIMS, we went on. The second step of that process was we did a LIMS supplier survey. So from the initial survey that was out to users, we identified that at that time there were 10 LIMS suppliers. So we took a more complex survey, and we took the questions and the concerns that we'd seen in the user survey, we took them to the suppliers. And it was designed around three key main themes. We did like it was a standard questionnaire, and we met with representatives. It was usually either over the phone or via a Teams sort of scenario, and we filled in that. So we really were able to dig that bit deeper. Like I say, there were 10, and it was all related to the questions and the concerns that have been brought up in the user survey. So what kind of things did we see? We saw gaps between users' responses and what the suppliers thought that they were providing. So we did identify some gaps. We realized there were communication issues between suppliers and the users, so how could we streamline that line of communication? And we also noticed that there was a lack of national guidance or standards for LIMS critical functionality. So and that's something we most certainly see. So what were the script recommendations? So script made 3 recommendations, and they were based on the responses from both of the previous surveys. So LIMS suppliers should get together with transfusion laboratory management, IT departments, and suppliers of other IT. So wherever possible, maximize that interoperability. We're going to minimize the manual input and maximize the interoperability between the systems. LIMS suppliers should work with the transfusion analyzers suppliers to ensure that results of all automated tests can be transferred. So wherever possible, again, minimizing the manual aspect. And LIMS suppliers should review processes within their systems for data flow with EPR systems to provide a fully automated process. So what did SHOT do? What did Script do next? If you've been on the SHOT website, Script has its own page. It's one of the buttons along the top, and there's all sorts of information on there. We really listened to what the user survey said, and we really tried to provide people with what we felt there were gaps. So there is a QR code there, but you can just visit the shop website as well. On the website, on the script page, you will see the responses from both the user survey and the supplier survey. So they're both available. We also took all those queries, all those concerns, and we created this using information technology for safe transfusion. It's a fantastic document. If you haven't, it's complete promotion for the script work, but if you haven't been on the website, please do have a look at this document. It's really cleverly arranged. If you are implementing new IT systems, or you've got issues in certain areas and you're thinking, could IT help me fill those gaps? So it's arranged in 2 different ways, and it's all interactive. So it's either arranged in the 10 steps of the transfusion pathway or by IT system. So for example, temperature monitoring or electronic blood management system. So however you need to view it, it is viewable in that format. So it's really worth having a look, and it will really give you some guidance. We've also got a document on how IT can support safe anti-D management in pregnancy. This will hopefully tie in with the recent SHOT notice that came out this week to do with anti-D and the gaps that are in the process. This is really broken down to all the different stages of the pregnancy, and including postnatally as well, where IT could improve the process for transfusion. We've also got things to do with electronic blood management. There was a part of the script survey, we focused on the electronic blood management system. So you can really go in, and that really digs a little deeper. And we've also got a business case example for implementing electronic blood management systems as well. So hopefully a helpful guide if you're in that process. These are some little tips and tricks that you can have a little look, and hopefully you could implement in your own business cases. We've also started to populate something called the Script IT Toolkit. So these are working documents from lab managers out there who have very kindly sent them to SHOT, and we have put them on the website as examples that if you are going through these processes, you could use. So for example, we've got LIMS specifications, we've got validation plans, we've got things to do with comms orders, we've got guidance, and we've got downtime procedures. So this is something we're hoping to build on over time as we get more examples. So really helpful if you're not sure where to start. This is absolutely the place to come, all on the script web page. Hopefully that will give you some guidance. We've also recently put on a information technology downtime aid memoir. Again, quite topical with the cyber attack. So it's well worth going and having a look on there, and having a little look about that business continuity plan, what kind of things to include. And thank you to Jen as well. Jen has recently given a presentation at the BTLP, the NECWAS last month, and we're going to put that on the SHOT website as well under the script page. It's not there on at the moment, but it will absolutely be there in the next couple of weeks, and you can see what kind of things Jen as well outlines in the IT downtime processes. We've got lots of educational resources. These are just a couple of examples. These are previous presentations to do with IT cases, or other presentations we've given to do with IT. So they all go on the website that you can hopefully implement in your own training packages as well. We've very recently implemented a lessons learnt process, because we are fully aware that lots of places are undergoing change and new projects, and you're doing that in difficult times and challenging circumstances. And we would really like to know how that went, and what we will do with that is we will share that with the transfusion community. It's just a very simple Microsoft Forms. If you can't access it via Forms, sometimes if you've got issues with your trust internet, we can send it you with an Excel spreadsheet as well. So don't let that put you off. If you've implemented a new project, what kind of things would you like others to learn? And we will absolutely share that, and we're going to start analysing that for trends. There's loads of other resources as well on there. So there's guidance, there's other tools that other groups have also implemented and used. So well worth a visit on there. And so following up on from all of those things, what kind of things are next steps. So our plan was always to facilitate workshop groups. So what we want is users and suppliers together to help improve those lines of communication, and each of them to explain what their future needs and wants are. So that's definitely in our plan. Developing a community of practice and a body of transfusion experts, that's absolutely what's happening. With the script team are not just SHOT, we have representatives from the whole of the UK, the 4 devolved nations, and we've got blood services as well on there. So people are really represented, and we're also creating a transfusion IT toolkit. So that's something that is already happening and will be continued to develop as well on the website. There is lots and lots of resources. Again, a little bit of a plug for the script page, but please do visit it. We have that's the most recent chapter from the IT, the IT chapter from the most recent SHOT report. We've also got the 10 steps on there. We've got a script SHOT bite. So if you're not sure what kind of things script have to offer, we have got a SHOT bite that's available on the SHOT website. And we've got, and like I say, we've got guidance, and we've got templates there as well. So hopefully that's a whistle-stop tour of the script, what we have on offer to the script page. So if you've got any questions in the QA, I'm hoping that Meg and Jen and Vicky will join us.
Lovely. Thank you very much, everybody. Thank you. They were really useful presentations and really good overview of what's been happening in the IT chapter and in the script group recently. So we've had quite a few questions popping in the chat. So I'm not going to go from the top to the bottom just because sorry, I get my teeth in today. We'll go from the top to the bottom just because Emma, there's the one at the bottom seem quite pertinent, and then we can follow them through if that's okay. So the first question I'm going to go for is, mentioned that alert fatigue a couple of times in the presentations. How can we overcome alert fatigue when we have so many IT systems in our workplace? Also, are there any resources to help prevent alert fatigue? So what can people do about it?
Who's going to start with that? I mean, first of all, I'll let others chip in, but I think this is actually something where human factors is really important. The fewer alerts we have, they need to be very relevant, they need to be very specific, and they need to make a difference to what you're going to do. So I think particularly when designing new systems and working with software providers, it's really important that they are aware of the data that we've got on alert fatigue. So I actually went to, I think, the Clinisys user group this year, and it was the subject of some discussion there. So I think the script group can work with these software providers, but it's also up to people to work locally to improve the alerts as well. I don't know what other people want to say.
Yeah, I would, to add to that, I would say review what you've got. If there's anything you don't need anymore, take it out. Make sure that it's actionable. It's got, if you're alerting me, what do you want me to do? Is there an action associated with it? Because I like the example Jen and Megan gave. It was quite vague. I don't think even most clinical staff, I don't think, would understand what that action was asking you to do. So I think, yeah, review what you don't need and make sure it's got a purpose.
Yeah, I would add to that as well, that just use them wisely when you have alerts, because if there are too many, people do just ignore them, unfortunately. So yeah, just be careful with them.
Okay, thank you. So another question is, introduction of IT systems takes a lot of time and resources. How do we ensure there is time and staff available within the working days for these projects? Who'd like to take that one?
Yeah, shall I kick off with that one? It is a real problem for us because it is big projects that we're trying to do. So it's really important from, if we talk from the laboratory side for a minute, to make sure that you know how much time this is going to take you, and it's built in to that project plan. And then looking for whether you need backfill or overtime or whatever people to do it, just making sure that you're very upfront that how much time it's going to take you, and that that's properly escalated up in your own organization so that people know and then they don't over expect you. For example, they don't expect you to be able to put in a system in 2 months when clearly it's going to take you 6 months, that sort of thing. So make sure it's all in the planning and the preparation, isn't it, with these projects?
Yep. Anybody else want to add to that, or shall we move on?
I think the other important thing is having a good communication between the IT department and your specialist area. I think what often happens is that everybody understands their own area, but they don't necessarily understand the other person's area. So I think using some of the SHOT resources to demonstrate to your IT department perhaps where the pitfalls are, where the problems are, and what transfusion needs and why it's different to other areas. I think use the sort of script resources and use other people's experience to do that. The other thing is, when we set up script, we felt that there wasn't really a training or qualification for people to become subject matter experts in IT, in transfusion IT. And trying to provide that education and support either from other people who've done the same thing in other places, which was the purpose, as Nikki said, of sharing experience and saying, what would you do if you were doing this again? What would you do differently? And what do you think the best thing you did was? And then, going on to perhaps introduce some sort of training or qualification later through script. So yeah, I think there are lots of things that you can do, but absolutely time to implement these systems should never be underestimated.
Fab, thank you, Megan. We've got another question here from Tim Williams, not from James. It says clinical systems EPRs are becoming increasingly sophisticated and complex, even more so than LIMS. Blood transfusion needs defined standards for EPRs as well as LIMS, especially with the national push for digital transformation. Will script be shifting focus from primarily LIMS only to EPRs and LIMS together? Go ahead, Jenny.
So script very much looks at EPRs and EBMS as well as LIMS. We definitely don't focus on LIMS. We're very aware of all the different systems that are out there, and we're trying to support with all of those systems. Obviously, LIMS is a big one for the laboratory, and a lot of transfusion safety is held within the LIMS. So it is a really important aspect within the transfusion pathway. But if you look on the website, you will see that we have got a lot of resources which look at the electronic patient record and the electronic blood management systems as well.
Okay. So a question here is, how are others dealing with the challenge of barcode scanning before the start of transfusion in the emergency service and OR, so operating room, where nurses and anaesthetists don't have a lot of time? Do you have a lower compliance?
So shall I pick that one up as well? From
Thanks,
our own experience of doing that in our hospitals, is that, yeah, sometimes the scanning, it is difficult to do the scanning before the transfusion, but we certainly in our hospitals expect the scan to be done as part of that event. And it is really important that we tell our clinical teams how important it is to make sure that what you're giving the patient actually is an emergency component and not a component that might be labelled for a different patient. So it's very important to get that scanning in before you start. I guess the key to this really is making sure that that process is easy and it's quick but safe. So don't put too many barriers into that scanning process or too many blocks into it to get it through. So you can get it through quickly, but you still have those safety features in there, and that it's very the process, the pathway is very streamlined. Don't make it difficult for the staff to do. I think often when you're putting in IT systems, that's one of the key things is to think about that you're not making it difficult for people to use the process. And I think Megan had on one of her slides that really good email signature that shows how key it is to make sure that the path is clear and the IT system supports safe practice and doesn't put added barriers in the way that you have to leap over in order to get to the end event.
I would also add, and perhaps somebody from SHOP can chip in, but the number of errors that are particularly of bedside identification that occur in those emergency situations and in the ED is higher with or without IT. So, I think if you've got a problem in an area where you're potentially, there's a greater risk of giving the wrong blood, then these systems should be positively considered for that reason, providing they're properly designed and they don't make it more difficult. I mean, I think the human factors side of things a lot of it is about usability. And whilst we absolutely have to think of patient safety benefits, we also need to think of what impact it's going to have on staff when these things are introduced. And staff need to be able to see the benefits for them as well as the benefits for patient safety.
Thank you. And we've just had a follow-up question on the question we had before about EPR. So while we're on the track, so they've followed it up with saying, well, how can we ensure that EPR suppliers implement recommendations from the transfusion community, including shot and script, which I suppose leads to the slightly to what Nikki was talking about involvement and the next steps.
I think that's right. I think by working together. So I think we need to share our problems and our successes with each other. And I think we can use script to approach manufacturers as well, because there's a bit more, we're doing it together. So yeah, I mean, there are lots of potential developments in EPRs, including, being able to record consent, issues around order comms, issues around prescribing blood and recording it in EPRs, traceability. There are lots of things that we could do, and we need to highlight those. I know, Oxford, for example, have got some very successful systems in place. So we need to learn from them. We need to learn from all of you as well.
Okay, thank you. Let's have a look. With the increase of cyber attacks around the country, do you think the IT systems are putting patients' data at risk?
One for you,
I guess.
Yeah, I was going to. Sorry, Jenny, go on.
It's fine. I was only going to say, if they're not managed properly at the organisation end, I mean, obviously, as organisations, we're obliged to protect our patients' data, so we need to have the right firewalls, etc., in place to make sure that we're safe. But it seems that no IT systems are completely safe from cyber attacks. At least that's the way it feels to me at the moment.
Yeah, and it's not just transfusion either, is it? It's when it goes down, it can come in via any part of the system, can't it? Often an outlying part. It's not necessarily obviously at the limb stage, but no other recent ones have been it was a knock-on of effect of limbs going of other aspects going down, where the answer was to shut the whole thing down, which is the right thing to do. So it's having that, when it not necessarily not the limbs being attacked, but having that continuity, that business continuity in place and practiced, so you know that you've got alternatives, because you don't know how long that will be either, do you? I mean, it may be days, it may be months, as in some cases. Yeah.
Thank you very much. It's time for a couple more, I think, just one or two more. So this question is about safety issues. So what should we do when there's a safety issue with an IT system and transfusion is identified? What can we do when the supplier does not engage when the issue is escalated to them? It is a big question.
Well, of course, problems with IT systems, if they have implications for patient safety and they're non-compliant, are reportable through the MHRA. So that's one of the things that you can do. I would say SHOT can also help. I mean, we've got a recent example where it was reported to us that there was lack of interoperability between the LIMS and a maternity system, which led to manual transcription of blood group and antibody data over and potential for error there. And it couldn't, it was attempted to be escalated by the trust involved, not fully successfully. And when it was escalated to script, we then helped, or SHOT helped by producing a problem statement, which we've published and circulated, and there was action quite quickly after that. Is that fair, Nikki?
I would also add to that to use your own risk assessment and governance processes within your organisation. So to make sure that you have assessed the risk of those issues to patients, and that the senior management within your own organisation are aware of that. And then often they will be supportive in terms of talking to the suppliers and making sure that they follow up on the obligation of the suppliers as well.
Thank you. Did you want to add anything, Nikki?
No, I was just going to say Megan's example was just showed that issues that had said couldn't be resolved were resolvable by contacting SHOT. So absolutely that, and then the script group, it was an excellent example of where things can change.
Lovely. Okay, thank you. So unfortunately, we've run out of time for more questions now. If there is anything burning, please do inbox us at SHOT. And I'm just going to hand over to Vera for some closing comments in the poll. Thank you all.
Hi, everyone. So thank you to all speakers for these absolutely fantastic talks and all for the engaging questions. It has been a very interesting and useful discussion, as Emma mentioned. If you have any burning questions that you were not asked, please just email to us and we'll forward them to the experts. So you can see a short poll for the attendings to answer. Your feedback is really welcomed and it helps us to improve these webinars. While you have those poll questions in your screen, I'd just like to inform that today's webinar has been recorded and it will be available on the SHOT website in the Meet the Experts page in a couple of weeks. On this page, we also found the registration link for our next webinar. It will take place on the 20th of January, and it will focus on the human factors and ergonomics in SHOT error incidents, and there is open for registration. For this session, there is no available certificate, but you can use your reflective practice document or any equivalent to record this webinar as a CPD activity. Again, if you have any questions that you were not answered today, please email us to the SHOT inbox. Our email address is shot@nhsbt.nhs.uk. I've also seen on Q&A if anyone wants to be involved on the script or work alongside with SHOT, just email to us and you are happy to be involved. We are just going to leave the poll for a little bit longer, a couple of seconds, so you have time to answer those questions. So the poll is now closed. I would like to thank you all for joining us today. It has been fantastic. Apologies, I didn't even realize that my video was off. Thank you all for joining us today. It has been fantastic, and I hope you have found this session very useful. We all now close the webinar and see you at the next one. Thank you very much.